Good morning. We're gonna have a session of a review of interesting cases of the third year of residence in the Department of Radiology of the Hospital Universitario José Eleuterio González. The first case we're gonna show is about a 18-year-old male with 3 months of weight loss and fever and progressive dyspnea. Well, the patient arrived to the emergency department because of the dyspnea, and the the doctor of that department asked for a chest film. We can see the PA chest film where you can see a pleural thickening on the right hemithorax. We may also see some displacement of the mediastinum to the left. Because of the weight loss of the patients, the doctors think about neoplasm, and because of the age, they ask for a testicle ultrasound. Here you can see the ultrasound of that patient. You can see the testicles; they are pretty normal, and also the flow on the testicles was normal. Then they ask for a CT scan. Here you can see a CT scan of this patient. He has a diffuse pleural thickening that also involves the mediastinal pleural, with also loculation, and you can see the thickening that was diffuse, pretty irregular borders, and also hepatomegaly and splenomegaly. Well, we are going to talk about some differentials about diffuse pleural thickening. How we can know this is a pleural thickening. Well, this is a non-standardized definition. In CT, we say we have a pleural thickening when when it measures more than 5 centimeters wide or 8 centimeters in the craniocaudal stent. One of the primary causes of pleural thickening is the exudative pleural effusion that is most commonly usually is unilateral. The pleural thickening is more a late finding. We can see adjacent pneumonia or other pulmonary inflammations initially. The pleural thickening persists despite the resolution of the pleural effusion, and the most common etiologies are infective or by streptococcal and staphylococcal species. When there is a nosocomial infection, the most common species are the gram-negative anaerobes and methicillin-resistant Staphylococcus aureus or MRSA. This can also be complicated by empyema that is also unilateral, and the pleural thickening it's also a late finding. The primary causes are tuberculosis or streptococcal pneumonia. This is an actual non-enhanced CT that shows I'm sorry, that shows bilateral pleural thickening and pleural collections. And these results from a disease. Another differential diagnosis is the asbestos-related pleural disease. It presents in 10% of the asbestos-exposed individuals. It affects primarily the bisexual pleura. There is also a bilateral involvement, and it is often associated with parenchymal bands and rounded atelectasis. Another important diagnosis is the pleural metastasis. This is about more than 90 of all pleural neoplasms. The primary locations of the neoplasms are lung, breast, ovary, and gastric carcinomas. But also, it is important, the lymphoma. This is more nodular, circumferential, and mediastinal. When there is a mediastinal pleural involvement, this is suggestive of malignancy. This can also simulate a benign pleural disease. And these coronal CT reconstructions, it shows extensive right pleural thickening in these patients with a metastatic renal cell carcinoma. Another differential diagnosis of the pleural thickening is the systemic lupus erythematosus and the rheumatoid arthritis. The most common manifestation of the intrathoracic, the most intrathoracic manifestation is the pleural thickening. 30 and 40 to 70 patients in autopsy series, respectively, 30 in lupus and 40 to 70 in arthritis, shows a pleural thickening in the autopsy. It is more common to see the pleural thickening that is unilateral more than bilateral. And the pleural effusion is frequently present. These patients shows a smooth left pleural thickening and also a pericardial effusion. The serositis is most common in lupus. Another differential diagnosis is the malignant mesothelioma. Most of the mesotheliomas results from asbestos exposure, where there is a nodular, circumferential, and mediastinal pleural involvement that is, as I said, suggestive of malignancy. Most of the mesotheliomas have a latency of up to 40 years. This can also simulate a benign pleural disease. Also, patients who underwent thoracotomy may have a mild residual pleural thickening that persists because of the postoperative hemothorax. It says the blood irritates the pleura, and it usually persists a mild residual thickening. Also, patients with pleural disease, the pleural disease remain stable over the time, and usually is adjacent to the pleural lung that underwent pleurodesis, most common from talc pleurodesis. And this is high attenuation deposits from talc that can mimic pleural calcifications. This patient underwent pleural pleurodesis with talc, and here we can see chronic atelectasis from the lower lobe, lower lobe. Another cause of pleural thickening is the intrathoracic drug reaction, and this is from patients who took these agents. This is most common bilateral than unilateral. It generally results after the cessation of the therapy. In our patients underwent to biopsy, and the pleural pathology report says in the right pleural cytology non-specific inflammatory alterations negative to tumoral cells, but the pleural biopsy said we had a high-grade non-Hodgkin lymphoma and the lymphoblastic variations with great mitosis. And that's it. Thank you.
Good morning. Let's continue with our interesting case. My name is Franklin Ordóñez. I am resident from the third year of radiology in this department in Hospital Universitario José Eleuterio González. Okay, our clinical issue is a middle-aged male arising either with seizure, long evolution, and refractory to the medical therapy. Wine color is put on the face and mental retardation. It decided to make a CT scan, and the CT detects subcortical subcortical calcifications. Also demonstrate loss of volume of the hemisphere and the parenchymal from this ipsilateral. Okay, the right choroid plexus is enlarged, and in this image we can see the tram track sign. The tract sign on the cortical and subcortical calcifications. Increase of the volume and density of the soft tissues. And the same findings are seen in the coronal and sagittal reconstructions. Bone CT shows enlargement of the right frontal sinus and the thin diplo. Okay, the same findings: calcification, cortical and subcortical, and the thin diplo, and has a polyp in the maxillary sinus. Okay, this is a volume rendering reconstruction, demonstrate a facial deformity. And with all findings, what is the diagnosis? Okay, the first diagnosis we think is, unlike most phacomatosis, Struck-Weber syndrome is a sporadic congenital malformation with not hereditary component, in which fetal cortical veins fail to develop normally. Imagined features are sequelae of progressive venous occlusion or chronic venous ischemia. Somatic mutation with nucleotide transition in GNAQ chromosome 9q21. It's a rare syndrome with incidence estimated at one case in 20 to 50,000 persons. The clinical of this patient is a port wine stain, seizure, hemipharesia, and visual disturbance. In imaging studies, we can see in CT these CT findings are non-hand CT, a gyral and subcortical white matter calcification not in the leptomeningeal angioma, progressive, generally posterior to the anterior, late cerebral atrophy, hyperneumatization of paranasal sinus and thin diplo. And contrast CT is a serpentine leptomeningeal enhancement, ipsilateral choroid plexus enlarged usual, choroid fissure is frontal involvement, and trigonal glomus is posterior involvement. Okay, in MRI and T1 early, increase of white matter volume suggest the pale angiomatosis and late atrophy of the white matter and gray matter. And T2 early is a transient hyperperfusion, accelerated middle mutation, and late increased T2 signal in region of gliosis and decreased cortical signal in region of calcification. and flared, and in the later state, we can see gliosis in involved lobes, swan, the classic sign, tram tract Herald classification, and in diffusion, restricted diffusion and acute ischemia. In the contrast, T1, in early state, we can see serpentine leptomeningeal enhancement, pial angiomatosis, and subarachnoidal space, and late state burnout, decreased pial enhancement, increased cortical and subcortical calcification, atrophy, and GERD enhancement choroidal plexus. In the venous MRI, progressive synovisual occlusion, lack of superficial cortical veins, and increase of the prominence deep collaterals, medullary or subependymal veins. In the spectrum, we can see increase of choline and decrease of NAA. Differential diagnosis is a Davidson-Mason. It's a unilateral brain atrophy, like our case. Have a compensatory Calvarian thinking and elevation of petrous right and hyperaeration of paranasal sinus. But in this case, the calcifications are not often, and we can remember, or the patient have a history of following in the utero and perinatal infarct. Other differential diagnosis is Rasmussen encephalitis. It's a rare case of focal intractable seizures, hemiatrophy, central in the medial temporal lobe, and around the sylvian fissure, and non-Calvarian fissure of David Mason. Okay, is the difference between date. And this is all about my case. Thank you.
Okay, that's continuum. And my name is Cristina Milet Jimenez Coliendes. I'm third year resident of the Hospital Universitario. And my case is a female of 16 years old without personal relevant antecedent, November of last year without generalist, abdominal pain increase, abdominal perimeter, and weight loss of 10 kilograms. Because of the symptoms, the patient was referred from the General Arroyo Hospital to the Hospital Regional Materno-Infantil on January 15th this year. An ultrasound is performed that reports an ovarian tumor on the left. So she goes to the Hospital Regional Materno-Infantil, where is performed an exploratory laparotomy without success to remove the tumor. So instead, biopsy was taken on January 28. She enters on February 5th, and pelvic ultrasound is performed. And Okay. We can see multiple lobulate images of salt echogenicity without visually bladder, uterus, and annex, as well as iris in moderate amount. Doppler color assessment present peripheral and central flow, which is why it is recommended to perform contrast abdominal perineal magnetic resonance is very assessment. Okay. We're seeing images wearing T2 in coronal code and heterogeneous tumor lobulate predominantly with cis areas zones of hemorrhage with multiple septs that compress to the bladder and displays the intestinal loops with multiple peripheral implants and ascites in abundant quantity without the finding they annexed. After the administration of gadolinium shows significant heterogeneous enhancement measuring before an annexal neoformative process with the possibility of the diagnosis of the malignant germinal tumors of the dysgerminal type in success. On February 4th, cytoreductive surgeries and hysterectomy adherent to the segment colon and parietal peritoneum with extension on amentum. The result of pathology reports metastatic endodermal sinus tumor. This tumor of yolk sac tumor are malignant neoplasms of germinal origin, which are characterized by their embryological differentiation from yolk sac structure. Its diagnosis is based in the combination of imaging tests associated with high plasma levels tumors markers such as alpha-fetoprotein. These tumors are very infrequent of rapid growth and tend to develop in adolescent and young women and reproductive age. Is a short duration symptoms, the 1 or 4 weeks, as the tumor grows rapidly, most commonly occur in women in second and third decades of life. Highly malignant tumor with poor prognosis, combination of cytoreductive surgery and chemotherapy. Elevate serum alpha-fetoprotein majority of patients. And characteristic of the imaging for ultrasound is predominantly salt mass with heterogeneous echogenicity and 6 space divided by sept, 6 areas, anechoic or hypoechoic, and multiple vessels may be seen within soil mass. CT encasing soil mass with areas low attenuation representing necrosis or hemorrhage, bright dot sign and capsular teeth. And MRI and T1 mainly soft mass of low signal and portions of high signal intensity may be present due to hemorrhage. In T2, high signal intensity, predominantly soil mass. Areas of very high signal intensity represent hemorrhage, and multiple signals voids can be seen related to hypervascularity tumor. Contrast T1 and a strong peripheral enhancement due to tumor hypervascular and irregular center necrosis and blind dot sign. The differential diagnostic is the dysherminoma. Dysherminoma usually is a very large lobulate cell mass, contain multiple fibrovascular sept. Calcification may be present and normal alpha fetoprotein levels. Choriocarcinoma, history of recent intra or extrauterine pregnancy. In the case of questionable type, presents intra-extrauterine trophoblastic disease, ovarian, theca lyrium cyst, or corpus lyrium cyst in gestional choriocarcinoma. Normal alpha fetoprotein, markedly elevate beta chorionic gonadotropin hormone. And embryonal carcinoma, usually very large mass and presentation. In serium, beta chorionic gonadotropin hormone levels are usually elevated. That's it. Thank you.
Okay, good morning. My name is Lorena Reyes Gaitán. I am a third-year resident at Centro Universitario de Imagen Diagnóstica, and today I'm gonna review one of the interesting cases. So, this case is about an 18-year-old male patient who was referred with medical history of uncontrolled high blood pressure despite treatment with 2 medications. On the physical examination, the clinician reports a low ankle brachial index, and also no abnormal blood test results were reported. Okay. So, as part of the diagnostic approach in this patient, a chest X-ray was performed. In this posterior anterior view of the chest, when we evaluate the soft tissues, there is no abnormality. But when we examine more carefully the bone structures, we can identify these small inferior rib notches. These little images on the inferior border of the ribs bilaterally. And the lung parenchyma shows no alteration, and the cardiothoracic index is also in a normal range, but what calls also our attention is this image at the border of the aorta, which simulates a tree configuration. So the next step in the evaluation of this patient was to perform a contrast-enhanced CT. On the long window, we confirmed that there is no airway or parenchymal pathology, and also there were no abnormality in the organs of the upper abdomen. But when we evaluate in maximum intensity projection in this oblique view of the thorax, what we can identify is, or the most relevant findings, are this narrowing in the descending aorta in a justaductal location. This narrowing was at about 27 millimeters from the origin of the left subclavian artery, and at the maximum stenosis site, the measure was of 5.5 times 3.5 millimeters. And we can visualize it better in this actual view. This is the site of the narrowing. Also, in maximum intensity projection in oblique views, we can identify this dilation of the internal mammary arteries, which distally connect to the external iliac arteries. And also, we can also identify dilation and in vessels with tortuous configuration at the intercostal arteries. So with all these findings, the diagnosis was an aortic coarctation. Okay, aortic coarctation involves an aortic narrowing, which frequently develops in a juxtaductal location. It can also extend to the aortic arch or even distally. The word coarctation comes from Latin coarctare, which means to contract. Okay, aortic coarctation represents about 7% of all congenital heart diseases. It occurs as a solitary lesion in about 82% of the cases, but it also has multiple associations, like with Turner syndrome, also bicuspid aortic valve, also intracranial aneurysm or atrial septal defects. It also has a male predominance with a male to female ratio of 1.5 to 1. Okay. The most common clinical features are systemic arterial hypertension, on the physical exploration also systolic murmur, and one of the most characteristic findings are an abnormal difference in the upper and lower extremity arterial pulses and pressures. Okay, on imaging, one of the most common findings are the tree sign, which is called because of this configuration of the aortic border with the shape of the number 3. It's due to the narrowing of the aorta. The other common finding in chest radiography is the inferior rib notching or Rosler sign. This sign is secondary to the dilated intercostal collateral vessels, which form as a way for the blood flow to reach or to access the descending aorta. These tortuous vessels erode the inferior border of the ribs. But this is a sign that we can see mainly in after a long evolution of the disease. This sign is not as common in patients younger than 5 years old, but it represents about it presents in about 70% of cases in older children or adults. The explanation to this dilation is because the blood flow through the aorta is obstructed by this narrowing, so blood finds other pathways like internal thoracic artery, and which through the intercostal vessels reach the distal descending aorta. Usually this alteration is seen from the 4th to the 8th ribs. Okay, other imaging studies, the gold standard for the diagnosis is conventional angiography. This is an invasive procedure. It requires contrast administration and also radiation exposure. Angiosity also requires contrast administration and radiation exposure, but it can identify very well the narrowing and also the dilated vessels, as well as angiomagnetic resonance, which not necessarily requires the administration of contrast, and it uses no radiation. But all these 3 techniques are capable of delineating the coarctation as well as the collateral vessels. The main differential diagnosis of this pathology is aortic pseudocoarctation, mainly in patients with atherosclerosis and an elongated aorta. Okay, the treatment in these patients is an urgency when the patient presents signs of congestive heart failure. In these cases, the main options are surgical resection of the site of the coarctation with end-to-end anastomosis, or also balloon dilation. In non-treated patients, they have poor prognosis. It reports a mortality of about 75% by the age of 46 years, and the main causes of death are congestive heart failure, also aortic rupture, which represents about 21% of the cases, and also complications of endocarditis, and finally intracranial hemorrhage in about 11.5% of the cases. And that's all.